Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the surgical care of patients with endocrine cancers with Dr. Jennifer Ogilvie. Dr. Ogilvie is an associate professor of surgery and chief of the section of endocrine surgery at the Yale School of Medicine. Here's Dr. Weiner.
We've only had a couple of surgeons recently, so I always like talking to surgeons, and we'll get going. Can you tell us a little bit about how you got interested in maybe first surgery, and then a little bit about what made you so interested in endocrine surgery?
I was one of those kind of, I guess, a little bit unusual kids who kind of knew I was fascinated in medicine from a very young age. So around 5, I was first asking grandparents all about their doctors and their different ailments. My grandfather was a surgeon, a general surgeon, ran surgery in Stanford Hospital just below us. And I was fascinated.
And maybe I can just interrupt and point out that he was probably a surgeon when there weren't very many women who were surgeons.
For sure. And actually, one of the funny family stories was that when I was about 5, I don't remember any of this, but he asked what I was going to do. And I said, I'm just going to be a doctor. And he said, oh, you'll make a very nice nurse. And I actually consider that a compliment now, but I told him, no, I'm just clarifying. I'm going to be a surgeon like you are. And that stayed pretty consistent. I really tried to talk myself out of it all through medical school. I sort of knew, the sacrifices that you do give up in the long training, as many of us in medicine do, and, wanted to make sure it was really worth that. But I could not see myself doing anything else. I had a really wonderful conversation after a large gastric operation for cancer where I was the medical student on the surgery side talking to the oncologist in the hall with the surgeon and listening to these two really great professors discuss the case. It was just clear as day that I wanted to be on the side that said, this is what we found, this is what we did. And as much as I loved what the oncologist was doing, receiving it and then planning the next stages of what was going to happen for that patient, it was just really simple. And I was like, oh, that's where I need to be. So that was surgery. And then endocrine surgery is a very, unfortunately, poorly named subspecialty of general surgery in that for us, it makes a lot of sense. But if you think about it, the endocrine system is quite vast and encompasses many different organs that produce hormones. And endocrine surgeons are actually really just focused on mainly 3 of those. So thyroid, parathyroid, which are both in the neck, and adrenal, which are above the kidneys. So patients with diseases of those organs, both benign and malignant tumors that often overproduce the hormones that they normally produce.
Because tumors in, for example, the pituitary are handled by neurosurgeons. Is that correct?
Correct. And tumors of the pancreas, so-called neuroendocrine tumors of the pancreas, and other parts of the gastrointestinal tract are handled by surgical oncologists usually. And then tumors of like the ovaries or testicles are handled by other specialists like OBGYN or gynecology, oncology, and urology. Endocrine surgery is a strangely named specialty, but it basically means focusing on tumors of thyroid, parathyroid, and adrenal glands. I was very fortunate where I trained in general surgery to have one of the founding fathers of the field of endocrine surgery, a wonderful man named Orlo Clark, there at University of California, San Francisco, where I trained. And at first, as a junior resident, I actually hated endocrine surgery because he was a brilliant man and a brilliant teacher and a very sort of scientific, just absolutely fascinated in the field. And it's quite complex when you first learn it. So I was, kind of a sleep-deprived intern just trying to get through and was just always like hoping that he wouldn't ask me questions because I always felt like there was too much to read and too much to know. But when I finally was able to go back and spend a consistent amount of time with him as a senior resident, I just fell in love with the field. It's intricate and sort of on the nerdier side of surgery because we do a lot of medicine as well. And there are beautiful, complex surgeries through kind of small, little intimate incisions and a lot of minimally invasive techniques. And all of that appealed to me a lot. I also kind of learned a little bit to my chagrin that I think it was really important to me to have most of my patients do well. I think I'm really good at taking care of sick people, or people that aren't going to do well. But I think I recognized in myself that it was going to be important for me to be able to tell people on a daily basis, you're going to be okay, and we're going to make you better.
So why don't we start talking about, and we'll take them one at a time, the two most common cancers you deal with, which are first, tumors of the thyroid, and second, tumors of the parathyroid glands.
Yeah.
And let's start with thyroid cancer.
Sure.
How common is thyroid cancer?
It's pretty common. It's actually moving up in the ranks more and more. It has tripled in incidence in the last 40 years. And we think that most of that is due to increased detection as we, do more and more imaging for different reasons. When we do ultrasounds of the arteries in the neck, or even ultrasounds of the heart, CAT scans for people who have been in motor vehicle accidents, et cetera, we incidentally find thyroid tumors on many of them. So part of the increased incidence that we're seeing is increased detection, but there's actually, if you sort of sift through that, there's also a true, real increase in the number of thyroid cancers. So it has become quite common, especially in women, but also in men.
How many people in the U.S. get thyroid cancer each year?
It's about 60,000.
It's a big number.
Yeah, and only about 11,000 die of thyroid cancer per year. So the vast majority of them are doing extremely well and live normal lives with treatment.
And that treatment is typically surgery?
Typically, it's surgery, although that even is a little bit of a moving target, a little bit of a change. What we've really seen in my career, which has been over the last 18 years, is a shift away from doing total thyroidectomies for thyroid cancer for everyone.
Which means removal of the whole thyroid.
Exactly. And doing more conservative, minimal surgery, which is called a lobectomy, where you're just taking out half of the thyroid where the tumor is located. And for a lot of these patients, with thyroid cancer, we have proven with sort of painstaking research that the oncologic outcomes are really equivalent if the tumor is in a low risk for recurrence category. So equivalent for removing half the thyroid versus the whole thyroid. So there's no benefit to doing additional invasive surgery.
And if you have to remove the whole thyroid, that means someone has to be on thyroid replacement the rest of their life?
Exactly. Sometimes when you take out half the thyroid, about 20% of people will need a supplement, but most of them will not need additional thyroid hormone.
But given how easy it is for somebody to take one pill a day, which is their thyroid replacement, I'm guessing that there are probably other complications from removing the entire thyroid gland.
Exactly. Luckily, all of us who, kind of specialize in this area and do a lot of these, the risks for complications are very low overall. However, as I like to tell patients, if I don't touch something in your body, I cannot injure it. It's, impossible for me to do it. So even though probably statistically the risks are similar to lobectomy versus total thyroidectomy, I think there are real benefits to patients for leaving some of their native tissue in place, especially if they get the same amount of oncologic benefit, meaning that they're at the same low risk of the tumor recurring or causing problems in the future.
And these are also cancers, if I remember correctly, that even when they spread to lymph nodes in the surrounding area, can still be very curable.
Exactly. That's true. Lymph node involvement for thyroid cancer is extremely common, probably at least 25%. But actually, if the tumors in the lymph nodes are quite small, so-called micrometastatic disease, and are limited to less than 5 lymph nodes that are positive, the oncologic, again, the outcomes are the same as if the lymph nodes were negative, which is very unusual for cancer, right? We usually see lymph node positivity as being, hand in hand with a higher risk for recurrence and for bad outcomes. But small amounts of disease in the lymph nodes for thyroid cancer does not appear to be associated with a worse outcome.
And then there are at least some number of thyroid cancers that are more worrisome, different types of thyroid cancer. And Maybe first you could just tell people about the types that are less worrisome and what we call them, and then move on and talk about the worrisome ones.
Yeah. So the most common thyroid cancer is also the one with the best outcome, the best prognosis, and that one is the vast majority of thyroid cancers, which is called papillary thyroid cancer. And that comes from the main kind of workhorse cell of the thyroid gland, which are called the thyroid follicular cells. Confusingly, the next most common cancer is called follicular thyroid cancer, and it's very similar. It's kind of a cousin to papillary cancer, but just looks a little bit different and acts a little bit differently as well. Papillary cancer.
And how does it act differently?
So papillary cancer typically spreads to lymph nodes and stays there. There definitely are shades of gray within the big spectrum of papillary cancer. And there are, as you said, some ones that are more aggressive and can spread elsewhere and really cause a lot of damage. And we'll hopefully talk a little bit about how we kind of zero in on those particular, kind of minority of cancers that are more aggressive. Follicular tumors and cancers typically spread through the blood system. So they spread so-called hematogenously, and they can go to distant places like the bones, brain, and elsewhere. Those are more rare than papillary and a little bit of a worse prognosis, although many of them, if they're limited to the thyroid and not spread, also do extremely well.
And then there are, and these are between papillary and follicular cancers. That's what, 85% of all thyroid cancers,
At least, like that. Probably a little bit more than 90. And then the remaining ones are the so-called poorly differentiated thyroid cancers, which is kind of along the lines towards the worst type, which is called anaplastic thyroid cancer, which is extremely rare, fortunately, and extremely aggressive. And then there's anaplastic itself. And then there's another kind of unusual cancer that's actually from a totally different cell type in the thyroid, the so-called medullary thyroid cancer. And that's about 5% of all thyroid cancers. That one is kind of in between the overall great prognosis of papillary and almost great prognosis of follicular cancer, and then the horrible prognosis of anaplastic. So medullary is sort of in between. A lot of patients are very well treated with thyroid surgery and medullary cancer and go on to have normal life expectancies, but it also can spread to distant areas like liver, most particularly.
And anaplastic cancer, which is the most aggressive, this is the cancer that Justice Rehnquist had many years ago?
Exactly. We think so. I don't think it ever was formally confirmed, but that's right.
But he had a cancer. He had a thyroid cancer that sadly took his life.
Yes. So that one is usually, we think, occurring in a long-standing papillary cancer that undergoes de-differentiation or transformation into a much more aggressive. It just kind of loses all ability to be controlled and can grow into structures and cause compromise of the airway and difficulty breathing and can be really quite awful and aggressive. There are some limited advances being made in that area, but it is a really, really tricky one to treat and one that needs a lot of aggressive care quickly.
And more research. Well, we're going to take a brief break. When we come back, we're going to continue with Dr. Jenny Ogilvie, and we're going to be talking about parathyroid cancers and adrenal cancers and whether there's any screening and prevention for these kinds of cancers, that is thyroid cancer and the other two types. And we'll be talking to you shortly.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Gastrointestinal Cancers is committed to detecting pancreatic cancer early and using state-of-the-art technology to treat the condition. Learn more at smilowcancerhospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths, but when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. This is Eric Weiner. I'm the director of the Yale Cancer Center and the president of Smilow Cancer Hospital, and I'm here with Yale Cancer Answers tonight with Dr. Jennifer Ogilvie, who is an associate professor of surgery and an expert in the management of individuals who have endocrine cancers or cancers of the thyroid, parathyroid, and adrenal glands. So, Jenny, we talked about thyroid cancer at reasonable length, and I'm going to ask you to move on to something that I think people are less familiar with, and that is tumors of the parathyroid. And I'm first going to ask how common these are, and then we can talk about some of the complications and ways that they're diagnosed.
Parathyroids are named by their Greek prefix para, which means next to the thyroid. So a really important part of almost any discussion I have with patients is confirming that what they're there to see me is about is the parathyroid, which is a different gland than the thyroid, but they live really close to each other. And sometimes the parathyroids are even found inside the thyroid, but mostly they're little lentil bean sized glands, 4 of them, 2 on each side, that live on the back or very closely associated with the back of the thyroid gland in the neck. Their job is to control calcium. And so they are usually very tight regulators of our calcium levels in our blood. And when we form parathyroid tumors, which happily are almost always benign tumors, but still very problematic, one or more than one of the parathyroids usually gets enlarged and overactive, and it just produces its parathyroid hormone, or PTH, all the time in high levels. And the calcium level in the blood then goes up. That can cause a whole bunch of problems, mainly loss of bone, because we store most of our calcium levels in our bones. So the parathyroid hormone kind of pulls the calcium out of the bone and makes them weak, causing something called osteoporosis. And the high calcium level in the blood then has to get filtered through the kidneys, and that can cause a burden on the kidneys. It can lead to kidney stones, calcium stones, and also kidney damage. So they can cause a whole bunch of damage, even though they're typically not cancerous, although about 0.5% of them can be parathyroid cancers.
And calcium regulation is pretty complicated, and it involves the parathyroids, and it involves the bones and the kidneys and your GI system as well. Is that correct?
Yep. And vitamin D is a big actor in there as well. So yes, very interesting little system that we have going on. And it usually works great, but like anything in our bodies, we can also have problems with it. And so hyperparathyroidism is typically picked up on lab tests. Sometimes people present with kidney stones or bad osteoporosis that's found on screening, but most of the time I would say a doctor finds an elevated calcium level on blood tests and then does some more testing and finds out that the parathyroids are overactive.
And do you ever diagnose hyperparathyroidism because someone comes in and they're confused, which is what happens when calcium levels go super high? But my sense is that with hyperparathyroidism, usually that's not the issue.
That's true. I think there's a different type of hypercalcemia that your area can see more often, where unfortunately the high calcium is due to spread of different and aggressive cancers in the bone. And those patients can present with lethargy, fatigue, really almost, really obtunded. Whereas our patients are typically functioning and going through their lives. However, when you talk to them, almost all of them say that they've been significantly more fatigued than they have before, that they forget, where they left their keys or what they were talking about. They have a little bit of difficulty concentrating. This got really confusing during COVID because I think almost everybody felt that way because of the various stresses and the actual horrible pandemic itself. But more than just the baseline of what we're all going through as a society, you really see higher levels of these symptoms in patients with hyperparathyroidism.
So this surgery sounds a little complicated. I mean, you're talking about a lentil bean organ, and even when there's a tumor, how big does it get? Is it 2 lentil beans or?
Great question. So for a single gland, which is called an adenoma, that becomes enlarged, it's typically sort of kidney bean to grape sized. But we've seen ones as big as the thyroid gland itself or even larger.
Really?
So they can get quite large, yes. When you have all 4 parathyroids that are overactive, that's called parathyroid hyperplasia. And those are much trickier than when they're big, because when they're big, they're easy to find. When they're just hyperplastic, they're about 2 lentil beans. And so those can really hide in strange places sometimes. So it can be a little tricky to find.
And do you ever have to remove all of them?
We can, but we don't. We really need at least one little parathyroid piece to control calcium levels. So if we remove all 4, even if they're all 4 abnormal, that actually gives patients a new disease, hypoparathyroidism, low calcium levels. And it's treatable, but it's a lot of medication. It's extra calcium and vitamin D supplementation pretty aggressively. We're not in the business of giving people new diseases, so we really try to leave just the right amount when we have to take out 3.5 glands, which is usually what
And are these ever
disease.
Malignant? You mentioned
Yes.
that they're mostly benign, but and
Yep.
if they're malignant, can they do what other cancers do, which is invade tissue around them, spread to other parts of the body, what have you?
Yeah, absolutely. Like almost any tissue in our body, they can be cancerous. Luckily, that's the very minority of these, so about 0.5%. We do have an unusually high number of parathyroid cancers here at Yale, I think because we're a tertiary referral center and we have seen a good number of these. And they do invade the thyroid gland or tissues around the thyroid gland, and they can be very, very tough to treat. So they can be recurrent. One of my partners has a pretty big experience with that complicated and rare problem. But there are treatments that we can do. Aggressive surgery is the most common.
And I asked you this about thyroid cancer, but how common are these hyperparathyroid tumors? Or these parathyroid,
really
I should say, the parathyroid tumors that lead to hyperparathyroidism.
Yeah. Hyperparathyroidism is probably about 1 in 200 women and about 1 in 400 men. So it's really pretty common, actually. It's often not picked up on lab tests as, it's the calcium can be mildly elevated and the, doctor doesn't, make much note of it. But it can be, kind of right in plain sight in a lot of blood work.
All right. And let's move on now and talk about perhaps the rarest of these. I think in some ways the most complicated oncologically, and that is tumors of the adrenal glands. And maybe first you can just remind people, what are those adrenal glands and where are they and what do they do? Why do we have them?
Sure. So adrenal glands are 2 pretty fascinating glands. They're about the size of your pinky finger if you bent it. So they're kind of little triangles in the normal situation, and they sit like little hats over the tops of the kidneys. There's one on each side, and they are fascinating in that they're kind of at least 4 different organs in one. So they have 4 different layers of cells that each produce a different hormone. So the center of them is almost like a nerve ending, and that produces some stress hormones. Adrenaline, we used to call it, but we call it epinephrine and norepinephrine, noradrenaline. The other layers produce cortisol and aldosterone, which helps with glucose control and metabolism and blood pressure. And then another layer produces sort of a precursor to our gonadal hormones or testosterone, which is called DHEAS, but is found in both women and men. So those complex little organs, each layer of those can form tumors. And then most of them, happily, like parathyroids, are benign, but can cause a whole bunch of problems because they overproduce their little hormone and cause a whole bunch of issues. But some of them can be malignant as well. And those are unfortunately very aggressive tumors that need a lot of kind of what we call a multimodal support for treatment. And surgery plus therapy.
And I'm guessing that when you have a tumor arising in one layer of the adrenal producing one hormone, it's probably not very easy just to remove that layer. That probably leads to removal of the adrenal itself.
Yes. Luckily, we do have a lot of redundancy in our body, so we can lose up to 3.5 of our parathyroids and still have normal calcium levels. You can lose one whole adrenal gland and still have normal hormone levels from the other adrenal gland. So we do have the ability to take out the entire adrenal to be able to get that tumor out. There are cases where we sometimes take out part of the adrenal gland for a particular type of tumor, but it's a little bit tricky and has its downsides as well.
And are there ever
typically
tumors simultaneously in both adrenals?
There are, and those are really tricky as well. So that's another area where you'd want to try to save some adrenal tissue if possible, if you're not worried about cancer. If you're worried about adrenal cancer based on what the imaging looks like or the presentation of the patient, the best treatment is pretty aggressive surgery to remove the adrenal gland and all the tissue around it, so that you have the best chance of getting control over it.
And how common are these cancers?
Adrenal cancers are very rare. So we're talking, way down at the bottom of the list for cancers, but we do see them, and they're important to really, get seen by a specialist and take kind of aggressive care of them.
And for the most part, all three of these cancers are cancers that are primarily managed by the endocrine surgeon. There's typically less involvement of medical oncologists in these cancers unless they're the rare, very aggressive ones. Is that accurate?
That's true. Our oncologists are, just for kind of historical and traditional different reasons, are managed mostly by specialized endocrinologists. Right. So those are kind of our oncology partners. And here we are really fortunate to have a lot of endocrinologists who focus on the treatment of these tumors as the oncologists. So we work really closely with them. We also are lucky to have a medical oncologist who helps us with the really most complex patients who need additional kind of chemotherapeutic or targeted therapy treatments.
Any screening for these cancers? Or, I guess thyroid cancer is the only one that's common enough that you would probably screen for it.
There's no recommended routine screening for thyroid cancer. I think the best screening is a good examination with your doctor. If a lump in the neck is palpated, it's typically going to be a benign thyroid nodule, but definitely should be investigated further.
Dr. Jennifer Ogilvie is an associate professor of surgery and chief of the section of endocrine surgery at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.